multidisciplinary cardiovascular research groups, one at the National Center of the Cardiovascular Research, or CENIC, and the other within the cardiovascular research area of the Instituto de Investigación del Hospital Universitario 12. Dr. Bueno's impressive career includes numerous national and international competitive grants, totaling over 1 million euros in recent years. He is the author and co-author of over 500 publications, most of them in leading journals as JAMA, Cell, etc. He has edited and co-edited 14 books and authored of 45 book chapters. He has over 130,000 citations and an H-index of 91. He has been selected as highly cited scientific of Web of Science. Dr. Bueno is also an associate professor of medicine in the Universidad Complutense de Madrid and has served as vice president of the Spanish Society of Cardiology, the SEC. Holds or has held numerous positions within the European Society of Cardiology, including Board of Consigliere, as representative to the European Medicines in the Agency, member of the Clinical Practice Guidelines Committee, Ethics Committee, Communication Committee, and the president of the Active Cardiovascular Care Association. Also serves as the advisor to the Spanish Ministry of Health, coordinating the cardiovascular health staff. Dr. Bueno trained as physician at the Universidad de Navarra, as a cardiologist at the Hospital General Universitario de Marañón, and completed his doctorate with an extraordinary doctoral work in '96 in the Universidad Complutense de Madrid. He obtained a diploma in design and statistics in health science from the Universidad Autónoma de Barcelona and a degree in integrated management of health systems from ESAD. He worked as a visiting professor in Yale in 2008, participating in a medical care program for the development and analysis of performance measures for cardiac pathologies. He also served as head of clinical cardiology at the Hospital General Universitario Gregorio Marañón until 2015, and Dr. Bueno has previously served as president of the Ischemic Heart Disease and Coronary Unit sections of the SEC, a member of the executives of the Council Quality of Care, Outcomes Research of the American Heart Association, and of the Society of Pediatric Cardiology in USA. He is a fellow of the AHA and ESC, and has received an ESC Silver Medal. Please join me in welcoming Dr. Bueno. It's an impressive curriculum.
Well, thank you. Thank you. Sorry for the delay, these technical aspects, and sorry for the long introduction. I'm going to tackle today something which is actually more everyday practice. Actually, I will focus on the, let's say, health perspective of something that we live every day, particularly women, but actually it's an issue of women and men. And I will raise it from a scientific perspective. So these two.
No, first recording.
Okay. Okay, here are my disclosures. Actually, nothing is relevant to the presentation of today. The presentation of today relates to whether we are similar or we are different, or there are different aspects, as the title says. So it's not only differences, is there equality, equity, and even discrimination? So the question here is there something about this in health? And the first question is whether we are similar. This is the easy one. I guess that most of you are aware of, but actually sex and gender is different. So for those who are not as familiar, sex relates to the biological differences. So that means usually set by genetic differences and then translates into physical, hormonal, what is basically unchangeable. That is the basis of sex. Gender is actually a different thing. It's a social construct and changes over time. This relates to patterns, relates to roles, relates to behaviors, and so on. So although it is frequently used exchangeably, it's actually different. So, and we will relate to both. Actually, you will see that actually they overlap, and that makes sometimes the analysis between men and women different, because some of the difference may be related to sex, biological differences, and some of them may be related to gender, which actually social-led differences or changes. So in fact, the first question is going to go to the sex or gender. So whether we relate to differences, and we will speak about differences as those explained by biological aspects, and we will speak about inequities when these differences are actually explained not by biological differences. So the first questions, are we similar or different? Well, that's the easy one. Obviously, we're different, but actually, this does have an impact on health. The first obvious differences, we have different chromosomes, and basically we have different hormones, which actually shape how we are. In fact, when there are, let's say, problems with the hormones or receptors, we have phenotypes that actually do not match the sex. And now you're watching this in newspapers with sport, men and women and so on. So that's a reality. But actually, that is the main difference in sex. But actually, there are more changes. For the same height, women are lighter. That actually seems to be a minimal thing, but actually has an impact. It has an impact, especially cardiovascular disease. There's been now, and I'm going to speak about bias. There's been a bias of considering women as a small men. That's a big mistake, but actually makes a difference. Because if, for instance, a cardiologist has to implant or stick a catheter in the arteries and stick a stent in the arteries of a woman, size will make a difference. So actually, that difference between the size of men and women make a difference. But also, it's not that. It's not only estrogens or sexual hormones. It's not only size. There are other differences. So the body composition between men and women is different. The metabolism is different. And actually, that applies, and I will speak about that in, for instance, pharmacology. Liver metabolism, renal function, and so on are different. But actually, body composition is different. The proportion of fat in women is higher than in men. And that is important because actually drugs either dilute in water or in fat. So it will actually have a different biodisponibility in women or in men. And I will come back to this later on. So, but here is a consequence of what is these hormonal differences. So these balls represent, is a risk score. It's a risk of having cardiovascular disease or dying. So from bottom to up, you can see the age, and then we have blood pressure, cholesterol, smoking, and so on. So in the left, we have women, in the right, we have men. And you can see for the same age, there is more red balls in the men's side going down there as compared with two women. That means that there are more men than women with high cardiovascular risk. And that, in a way, is led by estrogens, because estrogens are protective of vascular disease. So there is a physiological difference why men and women actually have different atherosclerotic risk. And that actually comes earlier. So in general, women tend to develop atherosclerosis 6 years later than men. So there's no question that we are different in terms of sex. Okay? But let's go to other aspects. When we go to medicine, in terms of women, this concept actually was coined like 25 years ago out of the bikini medicine. So we are different, but actually health in women has been mainly focused on the breasts and the reproductive tract. And all other aspects, including cardiovascular, these differences have been basically ignored, or at least not studied to the same extent as general. And that is very important. And I'm taking now the example of cardiovascular disease. Cardiovascular disease, with some reason, it has been considered a male's problem. And that is what everybody knows. If I ask all women here, what is the main fear of most women? It would be breast cancer, which is absolutely logical. Do you know how many women die per year in Spain due to breast cancer? Huh?
Very few.
Very few. Well, not so few. 6,000.
Wow.
6,000. Do you know how many women die of cardiovascular disease in Spain per year?
More than that.
60,000. 10 times more than breast cancer. So every woman knows how to care about breast cancer, how to prevent cell exploration. Do women know how to prevent? And actually, that the main risk of a woman is cardiovascular disease. Nobody knows. But actually, most professionals do not know it, even cardiologists. That's gender issue. That's a bias. Because the reality is that 26% of men die of cardiovascular disease, 32% of women die of cardiovascular disease. It's actually more a problem of women than of men, but nobody knows it. It's been not explained. And this is not sex. There's more than atherosclerosis. In fact, there's more women dying of cardiovascular disease in Spain than men. But women do not know it. But physicians do not know it. And while there's widespread programs of breast cancer prevention, which is absolutely a success case, we don't have the same for cardiovascular, which is the main killer of women. Why is that? So, in fact, you could say, well, actually, because more women live longer, that's logical. I mean, at the end, you have to die of something. But actually, you have premature death, that is, at a younger age, actually, the proportion of men and women who die of cardiovascular disease is very similar. So it is not. So we have a problem of information. We have a problem of communication. So let's talk about equity. So now I've shown you a few examples of gender aspects that actually affect health in general, cardiovascular disease. But let's give you some more examples. For instance, I show you the risk scores, which are based on traditional risk factors. So you all know them. Smoking, high blood pressure, high diabetes, high cholesterol. Those are the risk scores. So everyone knows it, sedentarism and so on. But actually, did you know that there are specific women-related risk factors? Martin, if you go to electronic health records, will you find these delivery-related or gestational-related risk factors? Unlikely. Do we have them in our electronic health records? We record hypertension and smoking. We don't have these gestational diabetes, pre-eclampsia, and so on, which actually are known risk factors because they are women-related, but we don't use it in the electronic health records. We don't ask for them. So actually, the risk calculators are actually biased to the men's risk. But actually, there's differences. Actually, these differences changes over time. It's not the same in pregnancy. There's also menopause where actually this estrogen protection disappears. And also there's also gynecological aspects that are usually unobstructed aspects that are not considered. And that's actually considered science or gynecologists, but actually have an impact on health as a whole. Now, osteoporosis, for instance, is known, but is very much ignored in cardiovascular disease. Let's get back to pharmacology. We said women are not small men. There are differences in liver function, in the metabolism, in renal function, and actually in the composition of body composition, fat and muscle and so on. That actually makes a difference. But how many drugs do you know with doses for men and with doses for women? Do you know any? Well, there's a few. There's low dose 500 milligrams of paracetamol. There's a few of them, but actually most doses are the same. Guess for which are designed? For a man, 75 kilos and so on. Are you surprised that women actually have more secondary effects than men? No. That's logical, because pharmacology is biased to the men's needs. And in fact, there's bias. Even in preclinical studies, most in cardiovascular, I guess that for all the diseases as well, are studied in male rats, male animals, in male cells, because you get rid of the changes with hormones. That actually makes a difference. They're very uncomfortable, these features of women changing over time. That's very uncomfortable. So actually, most of the studies are done on male animal models. So that actually brings a bias even from the basic results. Also, research is mostly performed in men, and so on. So actually, that's interesting enough. Most drugs are used in women than in men, but actually most research is developed in men than in women. And that is not sex. That is not differences. Well, but now we have precision medicine. Well, that is the future. We will solve it. And we will have it. Okay, so we have the traditional medicine, what treatment fits all, one dose fits all. That's what we basically have. Now we will have personalized diagnostics. Can you see the shapes? Well, it's surprising. It's only male shapes. Oh, good. And now we have system integration, and actually probably some of you are working in this personalized medicine and precision medicine. Again, male shapes. Oh, well, there's a woman who is a doctor who will receive that information. Actually, implicitly, we have this kind of biases all the time. But actually, do you know what is the main genetic difference, more prevalent in the world? That's an easy one. Come on, from precision medicine. So we can adjust to all genetic changes, but actually the most frequent prevalent genetic changes is XY chromosomes. Actually, medicine and pharmacology has not even adapted to the changes between men and women. And we're talking about precision medicine, who has not even considered the needs, the different needs between men and women. Let me give you one example. Yentl syndrome, New England Journal, paper 1991. That is nearly 35 years ago, long time. Bernabe Healy. If you know the Yentl is the protagonist, the character of this novel by Isaac Bashevis Singer. He was a Nobel Prize Jewish writer who wrote a story of Yentl was a woman who wanted to study the Talmud, Torah, but she was not allowed to because she was a woman. She made herself pass as a man You may have seen this film by Barbara Streisand, maybe familiar to you. So she had to pass as a man to do what she wanted, or to be treated as a man. This actually was an editorial from 2 papers that were published in that item. One was 2 studies from, one study in the left from 2 states in the United States, showing that the probability of undergoing coronary artery diagnosis, let's say coronary angiography and so on, in men and women actually was about between 30 and 45% higher in men than in women. The second one on the right was patients with heart failure. The main cause of heart failure is coronary artery disease. The probability of undergoing any study of seeking for cardiovascular disease, for coronary artery disease in men was nearly 90% higher in men than in women. So the editorial says, do we have women have to make ourselves pass as men to be treated as men, or to be managed as men? So this is the Gentle syndrome, which is the paradigm of gender bias in medicine 35 years ago. Still, we still have differences in care. This is one example: mortality of acute myocardial infarction in Black women. Yes, in Black women, in gray men, higher basically for most women at most ages, similar for post-discharge after a release of the hospital survivors in women and in men, and also symptoms, much more symptoms in women than in men. So basically, women who have an acute myocardial infarction are at a higher risk. But actually, women do receive less diagnostic tests, less coronary interventions, less guidelines, recommended treatments for prevention. So, and they still have more risk. And that actually has been persistent for years and years after the Gentle syndrome declaration. But who depends on it? You know what doctors do when we do something wrong? The patient is guilty. So that's something that we have done. So what's the problem? That the women actually do not tell us the symptoms right. And you're studying about symptoms and how to say. So we have actually several studies saying that actually the presentation of acute myocardial infarction in women is different from men. They do not have chest pain, or is atypical, and so on. We have several studies. You have here 7, you have many more. But one thing is interesting. Most of these studies are retrospective. That is, we collected electronic health records and we say it has typical chest pain or whatever. But actually, how would I write if I said she had chest pain, I discharged her and say, no worries, she came back with acute myocardial infarction. She didn't tell me well. So in fact, when we go to prospective studies, and this comes from Scotland, 1,200 patients consecutively in the emergency department, and you have different aspects of chest pain. You have in red and blue, women and men. Could you make a difference between one another? Actually, prospective studies do not show that there is any difference in chest pain between men and women when they're explored prospectively. We did that study between United States and Spain, and we saw that actually most women and most men actually presented with chest pain. When we asked them what was the patient response to the chest pain, actually the majority of them, well, half of them, did not think that that chest pain was actually related to the acute coronary problem. But actually, there were no difference between men and women. Do you know what was the only difference? Guess it? It was the professional perspective. Most professionals thought chest pain was coronary emerging for men than for women. It's a professional problem. It's a bias. Because still we think that is mostly a male problem. we still think that actually women have funny symptoms. But actually, that's not reality. It's not evidence-based. It's the way that we have been collecting the evidence. So let me give you a few. You don't have to take, it's just different diagnostic tests. Okay, I'm not going to get you the names. So basically, every test has sensitivity and specificity. So basically, green means good, yellow is okay, orange is so-so, and red is bad. Guess what is the most used diagnostic test in the real world? The one that actually works horrible for women. So, which is the most, let's say, affordable and easy to use. That actually brings problems. And in fact, once they reach to coronary angiography, that is seeing the coronaries from inside, and we see what there is obstructions inside, we see which are the black bars. Black bars are obstructions, and the other colors are different findings. And we have male, female for different conditions. So in the left are the, let's say, large myocardial infarction. In the middle are small myocardial infarctions. And the right, there are chest pains, just to be known what is going on. And you will see that actually the proportion of women with obstructive coronary artery disease is always lower for any clinical condition. So you would say, well, then there's a reason for, let's say, preventing doing coronary angiography in women. And in fact, in part, it can make sense. The problem is that actually part of myocardial infarction or coronary artery disease is what we call microvascular. This was only seen for, let's say, big arteries, but not for smaller coronary arteries, which is more prevalent in women. And that actually brings a bias in terms of deciding whether that explains or not. And here I'm talking about the overlap between biological differences and clinical decision-making. So sometimes differentiating between sex and gender is not that easy. But for instance, that would not explain this finding. This finding, again, this is a study that we did between US and Spain, more than 5,000 patients, younger patients with acute myocardial infarction. The probability, so when you have an acute myocardial infarction, heart attack, there's one clot in the coronary artery. In minutes, the heart starts dying. One part of the muscle starts dying. So you have to open as soon as possible. It has to be within 120 minutes. So just fast. So it has to be automatic. So in every model adjusted for anything, women have 60% more chances to be treated late as compared with the standards, as compared with men. Why? Well, we don't know. Maybe because the symptoms are different, maybe because the system, actually, when we have split into the patient-related and the system-related, actually both are longer for women than in men. I will come back to this later on. But actually, it's not only about coronary artery disease and the myth of a problem of males and atypical symptoms. Actually, the American Heart Association has forbidden to use the term atypical because actually it has fallen against women. But actually, the rate of pacemakers, defibrillators, resynchronization therapy, these are devices that we use in cardiology. You don't need to use it. But actually are always lower in women than in men. There's no biological reason why this happened. In fact, here, resynchronization therapy is actually more effective in women than in men, but it's used less in women than in men. Why? We don't know. Give you one example. Aortic valves. We have no medications for when the valves get sick, get stuck, do not open. So we have to open the chest and open the chest, have a specific aggressive surgery. Actually, we know that that surgery, women first worse with that surgery because there's different reasons, but actually the let's say, perioperative risk is higher in women than in men. So before we had to change that valve. Now we have developed valves that can be implanted through a catheter. We can stick a catheter here in the femoral artery, go up and replace the valve with a catheter. 1-2 hours, fantastic. One of the biggest advances in cardiology in the last decades. It's wonderful. Okay, so now we have seen, we did a study in Spain with all these TAVIs, it's called, and we saw how the surgical procedures went down over time and the transcatheter procedures went up, which makes sense. The only thing is quite expensive, but actually in terms of health, it are very good. And the other good thing is that actually this shift actually was earlier in women than in men. I say good, for once women have been considered earlier for ability advance. So good, we have good news. We did a study saying what was the probability of undergoing surgical in the left and transcatheter in the right, and we can see with a lot of logic that actually less women were operated with surgical procedures and more women were operated with catheters when they're hospitalized. But when we stratified, we standardized for population base, we actually found that women receive both less surgical procedures and less transcatheter. Why is it? We don't know. We don't have data to respond that, but we have to say that maybe there's a barrier for women with symptoms to reach the hospital or to be considered for TAVI. We don't know the reason, but there's kind of these things that we take for granted that actually we're doing things well, but it may or may not be the case. And I'm gonna bring it to some of reasons that may actually not be explained by biological differences. And one of these are determinants of health determinants. Actually, a lot of health does not depend on our bodies, our biologies. It is dependent. You know what is the biggest cardiovascular risk factor? CIP, the postal code. Okay, so the economical level, education level, loneliness, and so on are strong determinants of health as a whole and of cardiovascular health. And in fact, there has been now a way of gender-related health inequality. The issue is that actually all these determinants actually are different for men and for women. Well, they are the same, but the impact is completely different. So most of them actually impact more on women than in men. What are the clinical consequences of this? We really don't know yet. Let me give you an example. This is from our hospital. This is a PhD thesis from Guillermo, one of our nurses. So we collected 500 patients with acute myocardial infarction in the hospital. And we checked with the recommendations of the drugs, physical activity, diet, cardiac rehabilitations with actually all these saved lives. So we checked at 12 months how many of them were adherent to the recommended treatments. So we saw that actually at the 1 year, 60%, 67% were not adherent to all the medications, 40% to diet, physical activity, and so on. So majority of patients have dropped in their self-care. In fact, when we analyzed both, we see that 90% of patients in one way or another were not adherent to these life-saving medications. Not medications, care, self-care, including non-medical aspects. So we did an analysis. What are the predictors of this? Because it is challenging because we are very good in the hospital, but actually at the end, in the hospital, patient with any cardiac problem stays for a few days. And then they live for years and years, and self-care is critical. So at the end, it's very important to see what are the determinants of a proper self-care. So we actually found two of them were significant. Would you guess which one is? Would you say sex is one? Yes, no? Sure. Well, actually not. Sex was not different, but actually see this. The two main predictors of non-adherence to treatment were depressive symptoms and family care burden. So we are coming to social determinants of health. Actually, there were no biological explanation to this. So these have an impact. And here, this is psychosocial environment in Spain. This is from the La Caixa Social Observatory, which I like. So the proportion of women with low-level studies is lower as compared with men for any age group. The level of unemployment of women is similar for any education level and for any age level. And the salaries, the rates of the wages for women are usually lower in women than in men. However, when we go to the time for home care and family care, and this is all over the world, Spain is here around in the middle, but you can see that actually men spend basically half of the time of women dedicated to home care or family care. That's that impact. But there are other social aspects. And let me show you an example. That is the salaries of men and women after having the first child. Men's salary remains stable. Actually, women drop significantly and do not catch up over time. And these are social aspects, but actually have consequences. Social consequences, and medical consequences. This is the time spent on, studying, that would be the orange line, on productive market work, let's say for money. This is the orange, the pink line, and this is the domestic work, let's say home care. That is the women, the men's profile, and this is for women. They stop studying earlier. They catch up, they go to the market, but with a lower proportion. But actually, if you put together all the time spending working, women actually work much more than men. And that is a reality, at least in Spain. And that has consequences. So we have a crazy life. That is reality. That is our life. We have become crazy with work, with our times and so on. But actually, this craziness is even worse for women because they have to take care of both, let's say, the competitive work of professional life, but also still, and that's the role, still the role implicit is that home is mostly for women. There's one major issue now, and that's very much Spanish, because maybe in other countries there's a difference, which is taking care of sick persons in the family, older person, children, and so on. Actually, the time spent by women as compared with men is much higher. So caregivers are mostly women, and that actually is a non-paid work. And it actually has a huge impact on the economy. I would say a national economy, but actually has an impact on health. So here is this Association of Alzheimer, where there's a major issue. And you see 60% of caregivers actually think that their health is damaged. 40% of these caregivers, non-professionals, think that actually their health should be beyond the health of the person who is cared for. That is very typical. And 60% of these caregivers actually think they need attention because they are depressed, stressed, and so on. Do you see anything funny here? Again, the shapes are men, but the caregivers are women. So even the Alzheimer's Society has this bias in the presentation. So that's actually a reality of women working in Spain. So are you surprised that this has no consequences on health? In fact, women have much more prevalence of stress. Women have a much higher prevalence of anxiety at any age, and women have nearly double the prevalence of depression as compared with men at any age. Actually, depression is also more severe. Whether these are related to these economics or social, well, we don't know exactly, but probably has an impact. I wouldn't tell that probably that's a biological reason why this is like this. Okay? So in fact, I didn't say these are, and now we know them, that these are independent risk factors of cardiovascular disease. So we did a study between the US and Spain, and we found these were younger patients below 55 with acute myocardial infarction, men and women. And we analyzed different performance measures. And then you can see men in blue and women in red, that this physical function and mental function and quality of life and so on, that actually may actually perform better in all of these features as compared with women. But actually women were actually winning in two, which were depressive symptoms and stress. No surprise. In fact, this was the case. Female sex revealed to be an independent predictor of depression after acute myocardial infarction, with 60%, nearly 70% risk of having. This is the perceived stress in these patients. In the left, the values for, let's say, pre-myocardial infarction rates, higher always in women as compared with men, actually improved after 1 month and after 12 months, but actually these prevalences were always higher in women as compared with men. Return to work, these were younger patients. Actually, the rate of return to work was lower in women than in men. So there is a strong connection between health. So cardiologists, we have been very biological our approach, and we have already been very successful. We save a lot of lives. We treat acute coronary disease, we have angioplasties, stents, and now we can implant aortic valves in that. But we often do not consider these aspects which are essential in health. So are women unequal or at least unequally treated? Yes. There is evidence of this. And this is not a biological problem. But I think, is this discrimination? This is a strong question. We're talking about the health, which is basically one of the cores in our life. Well, let's go to the definition. So discrimination is the inequalities or inequities which are repeated over time against somebody, in this particular case against women, but based on prejudice. And that's one important shade of the definition. So let me show you an example. We were talking before about randomized trials. So these are randomized trials in different heart conditions: heart failure, atrial fibrillation, ischemic heart disease, and the proportion of women are always as compared with as men. But actually, this is the rates of mortality for each condition. So they are underrepresented. Why is this? Well, actually, FDA and EMA has stated that research has to be equally distributed between men and women. Actually, still does not occur. So the law, the rule is there, but it's not there. But let's talk about gender aspects. So there are gender traits: masculinity, femininity. So that actually, in fact, the masculinity and the femininity actually change between. So there's overlap between men and women. Has that any impact on that? So one question is here is this is a theoretical study in which a number of physicians were analyzed on these, let's say, gender perception between themselves. So they did a test, and they were evaluated about these gender traits that they have. This, let's say, ideology could be, it's not really ideology. And they were presented a clinical case. One patient who was a woman and one patient who was a man. And actually they were asked to do a test, angiography, a coronary angiography for the same patient with the same symptoms. And you could see that actually the way they had in their ideology actually influenced their decision making. I say, okay, but maybe they were smart and they knew about these differences in coronary arterial obstruction proportion, these differences. They say, well, then they give you, okay, I'm gonna give you a stress test, which is positive for angiography. Do you think that actually the differences narrow? That actually was the opposite. They widened. There was even more divergence between the decision-making on men and women. So this was a theoretical study, but there's a hypothesis that the way you perceive gender actually may impact your clinical decision-making. And that's something that it is more research. Let's see concordance between physician sex and patient sex. And this is a study showing patient perceptions. And actually there's two studies showing that there's correlation and some others that there is not. But even for outcomes, these divergence or concordance actually has conflicting results. So there may be a chance that being treated by a male physician or female physician may be different for men and particularly for women. And this is a study on surgeons in which being operated by a man, a surgeon, male surgeon or female surgeon actually made a difference. In cardiovascular surgery, there was a 9% lower risk of mortality if you were operated by a woman, a female doctor than a male. Actually, this concordance, the worst concordance was to be a female patient and have a male doctor. This is not a strong evidence. This is a small studies, but raises the issue that there were still these gender aspects in this concordance may actually have an impact on healthcare. So according to the definition, we cannot say that there is discrimination. There's no strong evidence on that, but there signals that there may be something. So I'm just finishing. It's no strange that actually the World Health Organization has set a strategy on women's health, and there's a number of issues, but actually good health, well-being, and gender equality are key aspects of this strategy. What they say gender equality, but gender equality means treating all the same. And if we just said, if we treat the same men and women, we're not making right. So the problem is not about equality, it's about equity. It's giving each one what they need to reach their needs. And this is what we need. So maybe the wording, probably they meant this, but it's equity, what we need to look for. And actually, for instance, in Spain, we run the Spanish strategy on cardiovascular health. And in fact, we have a gender equity with aspects as communication and information for citizens, for children, for professionals as different actions to be run, because this is a need. This is not a problem of cardiologists. This is not a problem of physicians or professionals, nurses. This is a problem of the society. And actually the society is changed in schools, basically, in childhood. So we need to go that. We're working in a European project. This is the Jakarta Joint Action Cardiovascular. This is one of developed this gender health, which is a map showing differences between men and women in these socio-economical aspects. And we will have a map, so it's kind of ecological based on regions, on the differences in health results. And we will try to see, and it's not evidence again, because you cannot infer causality, but we will see whether these huge differences between men and women in education, salaries, violence, and so on actually are associated with. And we will see how we are working. So this is one project that is funded by European Union. So at the end, every one of us has to do something about this. So first, we need to know. We need to acknowledge that this is a reality. The reality is that many people do not ignore it. They know it in the general, in the, let's say, general society. Some of them, they like it, some of them, they hate it, but actually this is a reality in the society. But actually that has an impact on the healthcare system, that has an impact on the health of women. So we have to do something. And there's something that we can do individually, but there's something that we can do, let's say, structurally from the institutions. And we have institutions which are completely unequal and they don't care and they perpetuate these situations. And you have these different levels of gender blind, they just ignore it. Gender sensitive, they acknowledge that they're different, they do nothing. Gender specific and gender transformative. There's really specific actions. And I'm very happy to see that actually this is one of the institutions who will be in the top rank, really having a strong program of equity, of working on gender and opportunities, which is really a privilege. So I thank you very much for being here and giving the opportunity to stay with you. And I hope, and I'm sure that the Barcelona Supercomputing Center has a strong opportunity to fill in some of the many gaps that are needed to narrow the gender gap in health, the gender gap in cardiovascular health and disease. Thank you very much for you.
Thank you, Hector, for this very nice talk, impressive. I don't know if someone in the room has questions. I think all of them are very impressive. And,
So for comments.
They cannot talk.
Maybe more of a comment. Well,
Yes.
I have
Go ahead.
many thoughts. I would like to talk to you later because I love this talk. And so thank you very much for sharing all of this information. I think it's very important, especially for the people that are not based in cardiology. About the surgeon gender, I read some articles about that, and I also read that it is possible that changes regarding the number of women in the teams. And apart from that, I wanted to ask, do you think also maybe even fat phobia could play a role in this? Because I know that statins are less prescribed to women in general, and I've heard a lot of horror histories about women going to cardiologists and them saying that it's probably related to weight, and maybe it's due to this difference in fat and how body is seeing in general. So,
well, no, I think there's evidence. So we have these funny issues about body fat and so on. Well, that's important, but at the end, we're in general in medicine, we try, and particularly in cardiology, we try to be evidence-based. So the evidence is that actually statin saves lives and saves lives in women and in men. So there's no reason, whatever you think, to withhold, let's say, life-saving therapies and men and women. But actually, that's the case. And there's many different reasons. And that was my point. So there's sex, there's gender, and part of the gender, the problem is the evidence, the generation of evidence is gender biased in many reasons, in many ways. So we have to correct. But actually, what you were saying now is an issue beyond the evidence. It's kind of nonsense, but actually has to be shown, because if we're not aware that it is happening, that actually will not be changed. So we need a lot of information, systematic assessment. And in fact, there's a law in Spain that actually all statistics have to be break out between men and women, but actually that doesn't happen. And in fact, if you remember the COVID pandemic at the beginning, there was difference between men and women that stopped for no reason, or whatever, or maybe there was a reason. So there's a lot of things. So at the end, we have the society, we have, let's say, a pyramid of, let's say, elitistic, they have universities, healthcare. So you cannot expect that the top of the pyramid changes if the base is unchanged. And of course, having more women as surgeons, as doctors, as researchers actually make a change. There's less women signing as first author or main authors in research, in general, in clinical trials. And actually, there's evidence that having a primary investigator, a female, a woman as a primary investigator, increases the recruitment of women. So yes, there's a lot of these things that needs to be, but actually, that needs to know, even women do not know it. Even female doctors ignore much of this because this is not taught in the universities.
Is another question there? Yeah.
You know, an amazing job, very, very nice, and it's true. I mean, very interesting to hear the facts about it. And now that we have the facts about this and the research, you have the numbers, what's your opinion on how long you think it's going to be fixed?
How long has it taken to reach the basic rights of women as compared with men? It has taken centuries, now decades. It has, let's say, advanced quite fast in the recent years, but it's actually the situation of equality, of equity between women and men. No. It will take years, but what I can tell you, that if we do nothing, it will take centuries. So I don't know how much. I think that if we do not specifically address this issue, if we don't specifically start changing from law in the schools, in the society, medical schools, that will take ages. So I think this is going to be, and I can tell you that I'm not maybe a representative of the average cardiologist or the average physician. I would say that many would actually deny this as a problem. I have colleagues that say that that's not right. Men and women treated equally, and that is fake. So it will take time. But anyway.
So on that note, thank you so much. It's been fantastic talk. I think these type of talks are very important. I feel very worried about the policies that are changing and removing the perspective of gender and sex in research in general. So how does that impact us, like in Europe and Spain? And if you feel like policies in the government are going to continue, or what's your take on this?
Well, absolutely. I mean, dreaming that that changes will come bottom up is a dream. I mean, it has happened with women's rights, but it has taken decades, if not centuries. So policies and laws are essential. But actually, top-down decisions have some reaction. And so I think they're needed. By my personal approach is that actually these needed to be evidence-based. If they're ideology-based, you will have half of the audience actually reacting against. So we have to be very careful, because actually when they're very ideologically based, which is fine, I mean, everyone can think about the same, but actually there's 50% of the population who actually opposes whatever you say. And I think that's why I'm very strong on getting evidence, strong evidence, data, that actually these differences, these inequalities have consequences. And there's no discussion when you show data. So I think we need policies, but we need to be, let's say, evidence-based policies rather than very ideological policies, because they have a counter reaction. And actually, we're seeing the world. We're seeing the United States, they have canceled everything, you know. So now we see in other countries where actually this is changing. So we have to be very careful, because now the trends in the society are not very favorable. Even in other countries which have inequalities, like Finland, Sweden, they're actually stepping back. So I think that's why I believe more in science and evidence-based on the consequences, because this is beyond, let's say, theoretical rights. This is about the fairness of the system. So I do believe on policies, but I'm a bit cautious about very strongly ideologically based policies, because actually creates a counter reaction.
And then we have the last question for Maria.
Thank you very much for your talk. That's really extremely interesting. And I wanted to ask, you explained that sometimes women arrive late or simply do not arrive. And sometimes heart attack or any other thing happens while you are working, right? You think that there is something in the protocols that companies develop that could change? I'm just proposing a very practical measure, no? At least at official bodies, universities, administrative organizations, BSc, there is something in our protocols that could change in order to detect that a woman is having a problem.
Absolutely, absolutely. Actually, in Catalonia, I think there was a code. In fact, there was a code actually doing a heads up for women. Saying one of the problems is about education, about the information that most women are not. Every woman knows that has a risk of breast cancer, but actually they're completely unaware that they have 1 in 3 chances of dying of cardiovascular disease. They ignore it. So maybe when they think about the chest pain, they may not think about it. But I don't think that's the reason. For instance, in the study that we did, actually, it was only 50%, but actually it was 50% in women and men. They didn't think, it were young patients. So they didn't think that actually was a heart attack what happened. So that's one thing. So we have to educate, and this has to come to schools. I think we have to go to very...
When you see one of your colleagues having pain, you should be able to identify.
Well, you have to call 112. That's it. Regardless if you're a woman or you're a man, I mean, just call 112. But there's one major issue there. So what typically a woman will do if she has a chest pain and she's at home? She will take care of everything, will fix things, the grandpa, the children, and then she will call. So it's not only about, let's say, medical health issue. There's about other, how I'm gonna leave everything, I'm cooking, I have my soup in the fire, I have the children, I have the grandmother there, they may actually, so we need more research on what are the reasons, because we may even inform and still have a problem. And actually, this is known for 30 years, and still the gap has narrowed a bit. It has narrowed more in the system, but it still is longer in the system. So it's not only the patients who actually take maybe half an hour longer for women to call, but actually even in the system, and we have experts that work in primary angioplasty taking care of patients, actually there's more delays in women than men. So the issue, what I try to give you is a broad overview that is not that simple, because it's not like statins. And even when we have strong, very sharp evidence that has to be treated, is not reaching the same way. Actually, it's broader. So at the end, and I think that's why it's relevant to institutions like this, which actually can help in distributing this communication, in helping in creating automatic systems of identify these sources of inequity, of the levels of inequity in the system. Well, I just mentioned cardiology because I'm a cardiologist, but I'm sure that probably happens all over the spread of specialties.
Okay, thank you, Hector. Thank you to everybody. And then I think it's time to go.
So they can